So it's my pleasure to introduce Dr. Kurt Peters, who is going to take over and actually chair this afternoon's session. He actually did his training in medicine at UBC, and he came then to this coast, unlike Peter Zed, who went the other way, and did his training in psychiatry at Dalhousie. He's worked as an outpatient psychiatrist with the Cole Harbour Community Team, but most recently, he's now the Deputy Clinical Director of Acute and Emergency Services and an Assistant Professor in the Department of Psychiatry. So I'm putting this afternoon's proceedings in his very capable hands. Thank you, Kurt.
Thank you very much, Heather, and welcome back to this afternoon session. It's a pleasure and an honor to be asked to chair the Bill McCormick Academic Day this afternoon, and my responsibility to try and keep us moving along in a timely fashion. So our next topic has to do with drug use, and there are clearly lots of drugs among us. We've all, or most of us, have imbibed stimulant drugs here this afternoon of the illicit variety. And I learned from Dr. Bob Pottle something new about drugs just today, about the problems with synthetic cannabinoids in the forensic setting. So it's a ever-evolving and changing field. So I'm looking forward to this next presentation and what we're going to learn from Dr. Sophie Gosselin. She did a residency in emergency medicine at McGill, followed by medical toxicology fellowship, and she's currently the associate professor and director at McGill University Health Center Medical Toxicology Consultation Service. And she works as a toxicologist for the Quebec and Alberta Poison Control Centers. So please welcome Dr. Gosselin to the podium.
Thank you. Let me know if I speak loud enough. I'm just going to try to be visible. I'm not very tall, and despite the highest hill I could comfortably walk in, I think maybe some of you may not see me. But if I'm going to try to speak loudly enough, if you can't hear me, just let me know and that'll be fine. I don't know how you want to function, if you have questions during the presentation or not. I'm very flexible with that, and because it's after lunch, I thought if you just have a question during the presentation, I'm very happy for you to raise your hand and we'll try to engage and wake everybody the postprandial hour. So I don't have any disclosures to make, except that I just get some honoraria sometimes when I speak for associations or for department and faculty. I don't have any honoraria or grant from industry. I don't speak for pharmaceutical industries, boards, or anything. So most of my work is through education and non-for-profit associations, such as days like this. So the objectives were fairly large in how what Dr. Milliken had asked me to talk about. So I know that Peter Zed discussed this morning about adverse effect and prescription drugs and drugs that we use in therapeutic setting. So what I'm going to talk about is things that technically are not allowed, not legal, and that's why we chose the title illicit. There's just a little exception in that list, opioids and dextromethorphan, that technically are drugs that are approved by Health Canada, heroin a little less, but we're going to talk about their use in contexts that have nothing to do with what we could prescribe them for therapeutic use. So drug use changes in society. It changes also because of supply, because of cost, because of culture, and also because of novelty. And since the advent of internet, which allows for online purchases through various countries, and none of it is very well controlled at borders, a lot of them are not labeled medication. They're labeled natural product, they're labeled complementary or alternative medicine, CAM, and there's a nice explanation of all that is on the Health Canada website. So you see various trends in use. So when there's online forums touting the great virtue of some new drugs, then you'll see a peak in the calls for the poison center, or you'll see a peak in the number of visits to the emergency department. Right now, there's, I don't know if you've been made aware, but there's a surge of synthetic cannabinoid presentations to the emergency department, particularly in New York State. And there was an alert by the American Association of Poison Control, such as these, cases are increasingly presenting to the emergency department. So I'm going to try to wake you up a little bit and ask, how many of you work in emergency departments in some capacity? Please raise your hand. Okay, how many work in outpatient practice or clinics? Okay. So fairly, this is something that you may encounter in your practice. Information exchange is fast, and people will get online and texting and group forum. And if you want to have fun, go on erowid.com. Don't do it at work, because usually most workplaces don't allow access to that particular site. But go at it at home, and you can see the experience of drug users put into a form. And it's a big machine that is sort of managed by Fire and Earth of Heroin. And there are these guys and women that are going through listing everybody's experience for drugs to try to see what's the good drug, bad drug, and then trying some screening process because it comes on site. So there's lots of information for people that want to use drugs about what are the effects that they're going to expect. The big problem is you never know what you're getting. You never know what you're going to get. There's not a lot of analytical process. Obviously, there's not a lot of quality control when people are marketing or making this in their basement. And that's one of the big problems. And if I can convey something to you today, and we'll have this discussion, I left it to the end, about the urine drug screens, is that as your role sometimes is to determine, is it a drug-induced psychosis or is it just a organic psychosis? Well, nowadays it's going to be very difficult to tell the difference because of the impact of the drugs on the brain. And even though the brain is plastic and the neuroplasticity is apparently a bit longer than in the first few years of youth, the effect of drugs on the brain, even though they are long gone from the system, may have left some changes that now are organic, for the better word of it. So just a bit of terminology. A prescription drug or medication, they're obtained via a legal route, okay, a legal prescription, a doctor prescription. They may not always be used as what we'd like, and I know that you probably see that patients are very creative in how they interpret our prescription. Non-prescription are medications that are obtained without a personal prescription. So dextromethorphan, diphenhydramine, ibuprofen, acetaminophen, those are all drugs. It's another term for over-the-counter, but some of them are not over-the-counter. And for the pharmacists here, if any, they're very much behind the counter, but you can get them without a prescription. And then the term misuse or non-medical use are used interchangeably in the literature. The definition is not very crystallized, and it just means that people are using it for not how they should. Either they're not using it because it's not their prescription, or it's their prescription, but they're not using it as they should have been, as they're prescribed. So that could mean somebody who you're prescribing lorazepam to sleep, and then they don't take it every day, and they sort of hoard it a little bit for the day when they're going to be stressed, and then they're going to take 2 or 3 when they're only meant to take 1. That's misuse. And abuse is when you have an intent to create an effect that's usually not allowed within the scope of therapeutic use. So abuse will say people injecting their lorazepam, snorting their lorazepam, snorting their Benadryl. So those are not part of a therapeutic use of a medication. And the intent is to get high most of the time. Or numb, but not necessarily to sleep or to decrease anxiety, which it was prescribed for. So when you're looking at prescription and non-prescription, 11% of admission in detox centers concern prescription medication. So 11%, and that was in 1999 to 2000, and the numbers that are coming up right now are most likely increasing, because if you've seen, I think this is going to be our next public health tsunami. And we have the HIV crisis in the 1990s, which was dealt with very nicely. Well, it's very rare that I see somebody in the emergency department with acute untreated HIV or for complication of opportunistic infection, because they're well treated, there's a good system in the community. Opiate abuse and prescription drug abuse is how can I say, a herd of wild horses that need to be tamed, really. It's going to be something that we'll have to address because it's a big public health. It claims our younger generation, which are very exploring all of these drugs and taking them. The access to them is very easy. So you have elderly people in my clinic that are going to hoard and not take their medication and sell them to the younger generation. And I see and I hear of these exchanges in my clinic, and I'm thinking, you know, this is done with a doctor's prescription, and that's what is, I think, a bit disconcerting. And maybe if we rationalize our prescription better, if we educated our patient better, if we built in a system where abuse and diversion was less possible, then maybe we could decrease the accessibility of at least the prescription drugs. I had a patient that came in. He says, oh, well, I'm buying fentanyl from my neighbor. And I said, really? And he shows me a stack of 50 patches of fentanyl. And I'm thinking, well, what is this lady doing with it? Is she not in pain? You know, like whoever is selling these drugs, so either they don't need them or they need to, or so it's a bit of an issue. So, but there's definitely an increase in the number of prescription and non-prescription abuse, and I think this is going to be seen in the psychiatry consults that you probably will have or are having. So there's a really large rise in abuse of opiate and benzo and all of the stimulants that are prescribed for ADHD. Much larger. Cannabis and cocaine, that's really steady. You know, they've got a good clientele. Users are happy with their product. And so those who are, you have the people that are smoking cannabis and they're very happy with it. And then you've got the people smoking cocaine, and they're very distinct personality types. But then the opiate and the benzos and the stimulant, you know, those are on the rise. So if you want to read something that was really good, and I thought it was pertinent because it was published recently and had Nova Scotia featured, so I thought how fitting. Look at Inventory, the guidelines on the treatment of harm resulting from prescription drug use. And it was published in March 2015. And so if anyone wants to have access for this, and they look at all of the steps and all of the mechanism that we could do to try to decrease harm in terms of rationalizing prescription, putting prescription on a weekly dispensing, or direct observation therapy, which, you know, patients don't like. They think I'm the, you know, senior sergeant of the fun police when I do that. But, you know, if that's what's going to make that they're not going to be abused, then that's what we have to do. So if you look at the Canadian-based survey data for the past year of abuse, look at cannabis, look at cocaine and crack, look at the over-counter or non-medication prescription, look at the pain reliever. This is where there's the biggest hike in pain. And then the cannabis, I think they're also lumping in the synthetic cannabinoids. So synthetic cannabinoid, or not synthetic marijuana, we'll get to that later. They're just synthetic drugs that act on the same receptor as marijuana, THC. And so they're sold at plant material, but it's a bit of a hoax because they could take whatever plant and then they sprinkle those synthetic chemical on top, and then they sell it as synthetic marijuana, but the compounds are very different. They just act on the same receptor. So opioids, most commonly abused prescription drug, very creative users. Oral, snorted, injected, and oxycodone is the one that's the most abused. So if you see in this very Canadian study published in 2009, there is an annual prescription increased from 558 to 509. It's almost a 33% increase. The opioids death also doubled. Oxycodone prescription were increased by 850%. So we're prescribing this as a professional group. And the majority of the cases, death was unintentional. So in the toxicology lingo, there's no such thing as an accident. Okay, so it's either intentional, you want to die, or intentional, you didn't want to die. And sometimes there's a bit of an overlap between an intention to take a medication and abuse it and an unintention to die from it. Okay, so some people, we call that recreational mishaps or something like that. So their intent was not to die, but they took it intentionally. Yes, they knew they were taking heroin. They knew they were taking hydromorphone, 18 milligrams IV. They crush it, and then they put an IV. So, but those are coming out from our prescription. So when you're seeing your patients, and we were looking at risk of suicide, sometimes it's not really a suicide, but it could be viewed as such, because if they're abusing drugs, then there's a definite risk sometimes that they will get a drug or a manufacturer that will have a higher percentage, or they'll be told this is a 4 milligram, but in fact it's an 18 milligram, so they get a lot more that they bargain for. And even though they're pretty good chemists at trying to see, oh, this works for me, this doesn't work for me in combination, when you listen to them, you're just blown away by their trial and error therapy with their N of 1 of themselves. But it's just very concerning. So I encourage you to ask in your questionnaire when you're seeing, particularly the younger generation, do you do opioids? Do you buy opioids? What do you do on Friday evening? Something like that, which is what a lot of them seems to at least having been exposed or having been offered. So there was this great study that was published in 2006, which was Opiate Canada. It was done in 7 Canadian cities, and they found that the users, actually heroin has gone down in popularity, and it's a lot more prescription opioids. And just to give you a bit of a ballpark of the costs that they had across Canada, average cost, so 30 milligrams of hydromorph content sells for $20, 4 milligrams of hydromorphine for $5. So clearly, you're getting an advantage into your purchase of the hydromorphone content, money for your milligram. And MS content 60 milligram, then that's only $35. One of the particularity of some of the opiates is methadone. So believe it or not, methadone is abused because people that we prescribe methadone to, and I know you've got a very strict and regimented methadone program in Quebec as well, but some people do sell their methadone. And they will sell their methadone to other users. And when somebody who is not habituated to opiates, somebody who's not tolerant to opiates, somebody who's not going to have opiate withdrawal syndrome, or when they're getting methadone, they're getting the double problems of having potential respiratory depression and death from the methadone, particularly little kids. And they can have prolonged QT if they're taking on a medication with prolonged QT, particularly citalopram, one of the SSRIs, or sotalol, or other antibiotics that will prolong the QT. Repeated use of opiates and repeated semi-coma, period of anoxia that do not make their way to hospital will induce a form of anoxic brain injury. And eventually you're going to lose a couple of IQ points with that. And so that's also taken into account when you have to evaluate somebody who has chronic opiate drug use, is that you have to ask them, when you use, do you use exactly how you should? Sometimes do you take more when you have a pain crisis? When you take more, do you have blackouts? And so the question about blackouts is very important because it can testify a bit of an anoxic respiration that they will spontaneously come back to, and that doesn't necessarily require naloxone. Although now there's talks, particularly in Canada, as they have in the US following the death of a prominent actor, to have naloxone injectable kit, a little bit functioning like our EpiPen, to prevent these deaths. But there's a lot of near misses. There's a lot of small arrests that only last a couple of seconds, or maybe, but that's enough for a couple of brain cells to die. And if that happens every time people get high, then eventually they'll functionally have brain atrophy that can manifest in all sorts of cognitive deficit. Particularly when people are doing what they call chasing the dragon, and chasing the tails of the dragon of the smoke, is when they're using aluminum foil to smoke the heroin, and that will cause a very distinct leukoencephalopathy that is not always reversible. So these people need a brain MRI, and then you see all the changes in the white matter, and it's and sometimes 45-year-old patients will have a brain as if they were 86. So this is, I think, is taken into account when you have to evaluate somebody for competency. I think this is something you may be asked for, or somebody with apparent frontal deficits. You have also to look at the adulterants, and none of this is very purified. So in order to sell or to give a kick to the effect, the drugs will be laced with strychnine, with scopolamine, or with clenbuterol, which used to be a beta-3 agonist, which used to be, hasn't been legal in Canada since 1997. Now it's very popular into the bodybuilding because it's a beta-3 agonist. It stimulates lipolysis. And so it's sold under the trademark in gyms as a complementary access medicine. And at the moment, it's still escaping the oversight of Santé Canada for medication. So lose weight while you sleep. So you can make muscle while you sleep. So you can see how very appealing it is to gym fanatics. So that's another question to ask, to your patients when you're evaluating. Do they go to the gym while we're promoting exercise? Do you use substances? Do you gym powder? They don't necessarily listen to what the doctors say, but they're very happy to listen to people with no degree in medicine that will, or in pharmacy, will give them all sorts of advice and will have, a very clear financial and economic incentive to sell them stuff. I don't understand, but that's the way it is, apparently. There's another thing that you may have heard in the news, which is in the opioid category, so it's Desomorphine. So the trade name of this drug is called Crocodile. It was a big issue in Russia, so it's 8 to 10 more potent than morphine, and it is produced from codeine, but it's produced with sulfur and with sulfuric acid, so it's produced in basement with very corrosive material, and all of these material are exceedingly corrosive to the skin, and this is why you see the picture down at the bottom. All of these have been pinched from internet, and you see tissue necrosis and gangrene. So if you have somebody who's just gotten into the novelty of this, well, maybe go to the internet, show them the picture, and maybe you say, is this really what you want to do? We haven't seen a case in Canada yet. I'm not aware of this here. Nancy Murphy, who's the director of the poison control here in Halifax, is a good friend of mine, and I've invited her to this talk. You haven't seen Crocodile in Nova Scotia? Okay, so hopefully you'll never will. Now, Oxyneo was a formulation meant to discourage IV, and then the company making Oxyneo, I forget what it is, I don't remember pharmaceutical company names, but anyway, they had big advertisement to saying it's safer than OxyContin, and everybody should move the prescription from Contin to Neo because they can't inject it, because if they're trying to mix it with water, it's got hydrogelling properties. Well, my patient have said, I just crush it, I put it in the microwave for 2 minutes, and then I inject it because they're destroying the jelly property. I'm like, okay. They're also very creative. So in the fentanyl patch that your neighbor is using for chronic pain, because the distribution of transdermic medication depends on the concentration gradient, there's still up to 25% of the drug left after 72 hours when the patch is discarded. So before, there used to be a racket in the emergency departments where the orderlies used to take up the old patch that were thrown into the regular rubbish bins and not into the pharmacy shop container. And so they used to collect it, and they had a nice sideline. One of them had a nice sideline selling old fentanyl patch because they brew the discarded, sweaty fentanyl patch that's been used for 72 hours to extract the residual fentanyl. So I don't know if you have a program into your own hospital, but fentanyl patches should be exchanged, okay, not discarded, because somebody's making a nice sideline with that. So the toxic effect of opioids: euphoria, sedation, respiration, and death. And remember all those little loss of points for every time they have blackouts and anoxic coma. You can also have acute lung injury. You can have pulmonary edema that's been well known since Osler in the 1880. And then there's the addiction problem. So the long-term effect of opioid is the addiction, and I think that's an entire topic on its own. Dextromethorphan, well, that's the cheap ecstasy. Abuse is increasing. They call it robo-tripping or Dex or triple C, and obviously you can buy it in the pharmacy. There's a quite complex receptor interaction, but it is a serotonin reuptake inhibitor, and so it can mimic ecstasy and a little bit of opioid receptor. So they get the effect of, the heroin and the ecstasy together. So apparently it's very popular in the teenager, robo-tripping. You can add that into your questionnaire. So it also acts at the PCP side, will give sedation, but with the serotonin uptake, you see them coming in with clonus, euphoria, white pupils, and so that's another drug of abuse that has dangerous effect. the other amphetamine, if one of your patient is regularly using amphetamine, then of course if they're also drinking and partying and dancing all night long and only drinking water because they're told they shouldn't drink alcohol with it, then they can have acute severe hyponatremia because the molecule of MDMA induces an acute SIADH. And so they will come in the emergency department with severe hyponatremia, 110, 112, and they will be seizing from brain edema. But they don't necessarily need to be very severe, you know, to have problems and the damage of on and off going brain edema. And that's always the challenge in the emergency department, as you know that the risk of central pontine myelolysis, if you bring their sodium back too quickly, is less problematic in the acute setting than in the chronic setting. But when they come to you in the emergency department, I don't know what they've been doing and if their sodium's been up and down and up and down, if they do this every day. So every time they're using amphetamine or MDMA, they may have a SIADH, and women are more at risk of it, and particularly premenopausal women, because the effect of the estrogen on the pump in the brain for the water exchange and the ADH. So that's why you may see more girls having problem with seizures and cerebral edema. So if one of your patients is using these medication, well, warn them about the toxic effect of having seizures and brain edema, and those have been fatal. Also, long-term use of amphetamine can cause a toxic effect acutely, but it's also a primer for stress. So have a look at some of the neurochemical testing when they look at the cytochrome oxidase activity, which is a measure of function. So long-term amphetamine exposure. And what is unclear is whether or not legal amphetamine that we prescribe, such as methylphenidate or dexamphetamine, would do the same thing. And so it induces changes that are neurochemical and behavioral that increases the potential for the brain to be stressed into learning and memory, anxiety, and so it decreases the cytochrome oxidase activity. So does this child with a little bit of a hyperactive behavior really does need those amphetamine, which mom may abuse on the weekend as well? That's been shown as well. So every prescription that you do has a potential for being abused or has a potential for long-term problems. So methamphetamine are also 4 times more potent than cocaine to provoke the dopamine peak, highly addictive, and the toxic effect you'll see, they have bruxism, so they wear up all of their teeth. Also has cardiovascular effect. That's actually debated in the literature. You see drug-sponsored studies saying, no, there's no problem with long-term methylphenidate or long-term stimulant prescribed for ADHD. That's because they all assume that everybody is taking them at the doses prescribed. Nobody has categorized the small doses and the high dose and those that are using more than what they should be. It's also an anorexian. So look at the difference between this young girl and 18 months later. This is on the Faces of Myth website, and there's others that are equally disturbing. So now the new kids on the block are the designer amphetamines. So you've got the category of the dimethoxyamphetamine. Those will leave severe vasoconstriction leading up to amputation. And then you have those that are fly derivative. This is just difference in structures that you don't need to remember. But those will have prolonged effect. So what we knew of amphetamine that was only going to last 6 to 12 hours now has the potential for lasting a lot longer. And so for you, evaluating somebody with a toxic psychosis, sometimes says, okay, well, I'll see what it is in 24 hours. Well, sometimes the washout needs to be a little bit longer, but sometimes the damage has been done. And even if there's no drug in their system, it is a drug-induced psychosis, but it's not because the drug is still in there producing the psychosis. And that's the blurry vision that is always a bit of a challenge when we're in the emergency department trying to say somebody is medically clear to be assessed by psychiatry. I think we have to refine our definition of medically clear, also to take into account that the drug may no longer be in their system, but it has produced damages that will be long-lasting. The legal amphetamine, high diversion potential. They're not always taking them as they should, and I have no idea why in the college students category there's been a surge of ADHD, but everybody's using these drugs to study. And I'm not sure that they're taking it as prescribed. In fact, I'm pretty sure they don't. Euphoria, psychosis, confusion, hallucination. And you can also see that with the caffeine and all of the drinks that they use to stay up and study. So you can have all the sympathomimetic, and to the lesser extent, the methylxanthine, such as caffeine, can produce confusion, hallucinations. And you may not always be able to test that on their screen, but that's something to ask when they're coming in. And there are very conflicting evidence about whether or not they have long-term cardiovascular effect. So you have this very recent study that looked at abuse liability of stimulant medication. So this has been done, and the short-acting formulations are much more at risk of abuse because they want the peak, the high peak. No case of bifenthrin has been reported in diversion, but atomoxetine and guanfacine, they're non-stimulants, so they're not fun, so nobody wants to abuse them. And then particularly in Western Canada, there's this novelty of using Talwin and Ritalin in combination for an increased side effect. So you see abuse and misuse independent related adverse drug reaction that's been reported to Health Canada. So look at Dexedrine, look at Ritalin, the proportion of adverse drug reaction. And that's always, only the numerator, because obviously we don't capture all of these effects. So Ritalin has a higher potential for abuse and higher potential for misuse or dependence than the other ones. And it doesn't seem to be related to the amount of prescription. It's related to the formulation itself. If we're looking at ADHD medication in Canada, so you look at what are available, and then you see that dextroamphetamine and methylphenidate coming in multiple doses have been those are all of the ones that are available. Those are the ones that are the most abused. Drug Abuse Network Dawn, so this is in the US, so see the related calls for amphetamine, dextroamphetamine, compared to methylphenidate. So that's clearly related to a prescription change. So we're going to talk about ketamine. I know that there's initially used as a veterinary anesthetic, has PCP-like properties, so that's why you'll see sometimes the multi-directional nystagmus. Toxic effect, people can be in what they call the K-hole. So it's this place where they're very dysphoric, they're vomiting, they've got hallucination. Usually the emergency department is pretty switched to the fact that this is not acute psychosis. But then sometimes what you'll see in the chronic setting, you'll see the ketamine-induced cystitis. So you may see this in your clinic or in your emergency department, in your outpatient setting, that chronic ketamine users, and a lot of the people working as an escort will use ketamine so that they can be dissociated during their work hours. And so they have cystitis, and they're being worked up all the time. They're being given antibiotics all the time. The cultures always come back negative, and has this urgency incontinence that you don't see in regular interstitial cystitis. Has gone into requiring cystostomy. And so it's not always reversible. So if you keep that in mind, and if you have a ketamine user and that comes with urinary problem, to be them aware, refer them to urologist, because this is something that's emerged in the literature since it was first reported in 2009 by a group of urologists in Asia. I'm not sure what we're going to happen, because do you have ketamine as a chronic pain adjuvant in... There's some chronic pain clinics that are now portraying low-dose ketamine. There's a lot of emergency studies looking at ketamine as an acute pain in the emergency department. So I don't know what's going to happen to these side effects. GHB is another drug. It's on the rise. I don't know, some neurologists who use Xyrem, which is sodium oxybate, which is precursor of the GHB for narcolepsy. I don't know, does anyone here have ever prescribed Xyrem? So it could give similar effect to GHB. And then the long-term toxicity of GHB can present, again, as early dementia with cognitive deficit, long-term memory. And again, we don't know if it's the same thing with the opiates, is whether or not it's a direct effect of the drug, a direct toxicity to the cells, or if the resultant of several mini anoxic injuries. And there's also a question of all the oxidative stress, as I've illustrated with the picture with the cytochrome oxidase. Bath salts. Labeled as such to avoid legal problem. Nobody puts this in their bathtub. So they're a derivative of cathinone, which is a plant, and there's actually one medication that is illegal, cathinone. Does anyone know which one? Come on. Bupropion, okay, is in a similar structure than the cathinone. So the effect of ephedrine-like agitation to psychosis, hallucination. So if your patient is abusing their own bupropion, they can present with toxic effect like that. So that's another thing that you can ask. What else do you do? How do you take your medication? Do you take your medication as prescribed? And sometimes they'll be very candid in telling you that, well, sometimes they take 2 or they take 3. Synthetic cannabinoid, as described, otherwise known as spice, which has nothing to do with the Dune movie of the 1980s. They were initially synthesized for medical research into the endocannabinoid system. And they're meant to have cannabinoid receptor 1 and cannabinoid receptor 2 activity. And it's not synthetic marijuana, they just bind to the receptor. So their proper name would be cannabinoid receptor agonist, okay? Synthetic cannabinoid receptor agonist. But when people in the late term are calling them synthetic marijuana, well, that's inaccurate. So one of those is dronabinol, that's been marketed as an appetite stimulant, and the toxic effect are dysphoria, altered perception, hyperphagia, all the way to chronic terms of immunosuppression. So when they're coming very, very dysphoric, for a psychiatrist, I think this is something that you need to know, that these new things are circulating, and so you may want to ask, well, are you taking any powder? Anyway, you'll look very, in the know if you're asking them about the spice. I have to tell you that one time I was coming back from Australia, and I'd purchased some Australian spices, the native spices, and I'd put them in my thing, and I'd written on my Health Canada declaration, what are you bringing back? Spices. And then my whole suitcase was open and searched and this and that, because they thought I'd said spice, and it was at the time where it was popular into the news. And I should have said cooking spices or something like that. So just a word of caution if you're traveling. Maybe do not write, I am bringing back spice, because it may trigger a chain of event that may delay you getting home. So here, again, when I looked, I said, oh, is there any spice in Halifax? Well, the first thing came out to this, spice condo, which I think has hardly anything to do with the drug. But that's the only thing that comes out. So I don't think you've had a huge problem with spice in Nova Scotia. Now, lastly, we'll go to some of the older stuff. Benzodiazepine, they've been around for a long time. Long-term use is associated with cognitive deficits, and the geriatrician will be able to tell you that. Now, I know as a group, psychiatrists are one of the groups that prescribes a lot of benzodiazepine. And so I don't know whether or not you're aware of these long-term effects, and sometimes I guess it's a risk-benefit, that you have to take, and it's not always easy, and then you have to balance, well, I know there's long-term risks of benzodiazepine, but sometimes it's a necessary evil. But just remember that the cognitive deficit, if people have been taking benzos for a long time, lasts well beyond cessation, and they mimic early dementia. And the chronic use of benzos also increase the risk of dementia, irregardless of when you stop benzos. So the longer people are on benzodiazepine, the higher the risk of them developing dementia. It's a very complicated addiction, very complicated weaning process. Sometimes it'll take 3 months, 4 months, and it's very, very difficult to do. You almost can't decrease by more than 10% for every 4 to 6 weeks. So it's a very addictive substance, very difficult weaning. And the rate of seizure if stopped abruptly has not well been described. So we always recommend people not to stop abruptly, but exactly, I haven't seen a huge epidemic of status epilepticus, and I'm sure it happens when the supply ends and they have to go and get it elsewhere. Cannabis, heavy chronic users, will have problems with cannabis. Now we're not sure exactly what's going to happen with the medical marijuana. And I added a slide at the end because just yesterday, the day before, an article was published as a very nice review of all of the literature for all of the indications that medical marijuana can be used. And I'll give you the reference at the end of the slide, but it's a very nicely done review. And basically, there's not a lot of data. The toxic effect, it's been linked to schizophrenia. It's been linked to cannabis-induced hyperemesis. So cannabis-induced hyperemesis, even though cannabis is supposed to be an antiemetic, can induce cyclic vomiting. So for those taking care of young girl with eating disorder and they come in with cyclic vomiting, then ask whether or not they're using cannabis or they're smoking cannabis, because that could be a cause of it. And apparently it has to do with the VZ skin receptor, and the only thing that seems to alleviate the vomiting is hot showers. So if you have a young girl who you're being evaluating for eating disorder or stress, who keeps vomiting and has these issues, or migraine, then if you ask the question whether or not, well, what does it make it go away, and she tells you, well, hot baths or hot shower, okay, maybe ask whether or not there's covert or very cannabis use. So problems with cognitive function, you see the brains and you see the changes in brain structure with long-term cannabis use. I have no idea what is going to happen with the medical cannabinoid or even the smoked marijuana, okay, because the legal marijuana that's being introduced into our society, those are not synthetic cannabinoids. This is plant marijuana that's being smoked, and so there's a very different, there's a difficulty in measuring the therapeutic effect of something when you're smoking than when it's actually a pill or medication that you can compare to other non-cannabinoid alternative. But it impairs driving skills, it impairs attention, it impairs memory, cognitive function, anger management, very frontal activity, even after cessation of the drug or smoking. And we've been able to prove it with functional imaging. Again, ethanol, which is another drug that I suspect would not really pass Health Canada standard as a medication today, nor would caffeine would, but you know, those are two legal evils. We all well know the effect of acute intoxication, but the long-term effect on the liver, on the hematopoietism, and on the brain. Some people have drunk so much in their entire life that at 45, they look drunk even when they're sober. They're ataxic, they've got no cerebellum, they've got very frontal. So when you have a patient who is starting to get having some cognitive dysfunction, and you do a proper alcohol history, it may be a good idea to image their brain, just to have a look at how much atrophy there is. And then you have to test them with their capacity, you have to do the mini-mental, a MOCA test, their driving skills need to be assessed. So the long-term effect of alcohol are not only on the liver and cirrhosis. And there's also the heart, cardiomyopathy, alcohol-induced cardiomyopathy. So this is another thing to keep in mind. And we clearly see the effect. A 15-year-old male that's a non-drinker, and look at the brain activity with a 15-year-old male heavy drinker. So this, I think as a collectivity, we have to warn our younger generation, and the binge drinking and the party drinking and the college drinking and all of those parties may have lasting effect on brain development and cognition. And now we'll come to the last part of this, the controversial part. So there's many different commercial assays, and I know I'm always having interesting discussion with the psychiatrists that do the emergency psychiatry at the emergency department where I work, because there's variable detection cutoff. There's lots of false positive. And I think some of the psychiatrists, and I don't know the practice here, is they're relying on a negative urine drug screen for administrative issues, for transfers, for admission. Is that the case here in your province? Do you have a urine tox screen as a standard case? For methadone clinics to see compliance to the treatment, yes? Not in the emergency department. Oh, wow. Oh, that's good. In where I work. Nancy, okay, for her work, for her pioneer work in informing you that this is useless. So these tests are useless. Well, you know, there's lots of, a negative result could imply it's not there. It's there, but it's below the detection threshold, or this test is not designed to detect this particular structure. And just to point to you how interesting this can be, if ever you were, you know, maybe not to do them in the do you have completely abandoned the use of urine drug screen? No, okay, all right. So So you see false positive drug screen. There's a couple of articles of what clinician needs to know. So pantoprazole can give a false positive for THC. So there was this young girl who was in for cyclic vomiting, and she was given an IV pantoprazole bolus in the emergency department. Came in, people said, well, maybe this is drug-induced cannabinoid hyperemesis. Did the urine drug screen, and it lit up for THC. And she was like, no, I've never done. And when they sent it for confirmatory, there was no THC. So it's the PPI. Now everybody, and their cat is on proton pump inhibitor for various stuff. So I think that you have to be careful in how you're evaluating the THC result of your urine drug screen. Ranitidine, there was this very unfortunate case of a woman delivering, and some of the social worker had doubts because she had admitted that she had done a couple of ecstasy and speed at a party prior to a pregnancy, but no drug use during pregnancy. They did a urine drug screen, came up positive for amphetamine. Baby was taken away. Legal, whatever. She's given ranitidine for hyperemesis during a lot of her pregnancy and at the end. Chlorpromazine, which is a medication that you sometimes use as well. Bupropion also cross-reacts with amphetamine. Antibiotics, dextromethorphan. So there's and cyclobenzaprine as well. Unexpected interference of baby wash product with the cannabinoid immunoassay, and I think that may have implication in forensic as well and youth protection. So you need to know when you're doing some tests that maybe it's better to go for the confirmatory gas chromatography testing and not just relying on this immunoassay. This 13-year-old girl that I was telling you about with the proton pump inhibitor, you'll get the slide, so if you want to go in and look at the references yourself. False positive PCP assay by one of the amphetamine MDPV. And then there's only one assay that's looking at the drug of abuse that's done with Rendox. So the latest drug of abuse, Batzol, cannabinoids that I've been talking about are not even part of the reagent strip for the regular urine drug screen. And this is, I think, the best urine drug screen practical guide for a clinician that was published in the Mayo Clinic Proceeding. Well, it tells you how long things can be detected, and it can also tell you the list of all the things that can give false positive too. So Benadryl can give a false positive for methadone as well. So you need to ask, and I think maybe some of my patients know this, and I think they may be just taking a lot of Benadryl and selling them methadone, but it's very difficult for me to prove that. So some people will still have a validity for urine drug screening to monitor and adhere compliance to drug, but we've got to be well aware of all the things that of the detection cutoff and threshold. And so, again, I think this is what they do not contribute to the immediate clinical management. And particularly in Canada, there was a study done in Ontario that shown that they do not even when we do the test, we don't even change our management with the results. So do you really, really need that emergency drug screen? Was a nice editorial that was done by Milton Tenenbaum, a prominent toxicologist from Canada. And conclusion in the emergency drug screen is very unlikely to alter your management. But I think that if you are going to do it, you need to know the limitation of the test, and you need to know the potential drugs, and you need to do a very, very careful drug history to make sure that there's no cross-reactivity from it. This is the new open access talk for the narrative review, which if you wanted to have the reference of, I thought I should put it for you. So in conclusion, I thank you for your attention, and I really would like you to be vigilant about your prescriptions that have a potential to be used for something entirely different than what you would like them to. Ask questions to try to prevent potential long-term complication. Try to put barrier to diversion. Be stiff. Write a prescription. They have to go and get it weekly. They have to go and get it every day. And be mindful to the limitation of the drugs testing that you use for your clinical decision. So I'm ready to take any questions.
Thank you very much for a very informative, interesting, and sometimes disturbing presentation. So please, we've got some time for some questions.
Hi. Hi again. I don't have a question, just something to pass on to you, but thank you for the presentation. It's very illuminating. At the Forensic Hospital here, we have a significant problem with synthetic cannabis. There's a shop downtown in Dartmouth that sells it, and we use the urine drug screen. But the problem is it's a cat and mouse game, and the compounds are always changing. So we see people who are clearly intoxicated. It sort of puts them in a psychotic, delirious, drooling state, causes chronic tremor in some of our guys, and we've discovered that lamotrigine causes false positives for it. But it doesn't seem to be an issue in other areas of mental health, but the forensic patients are certainly using it and liking it.